This program is brought to you by Emory University.
Our speaker this morning, as you can see on your screen, is Dr. Ahmed AlBadri. Ahmed is one of our fourth-year fellows in the clinical investigator track. He's originally from Lebanon, did his internal medicine residency in New York City at Lenox Hill Hospital, then went and did a research fellowship out in Los Angeles at Cedars-Sinai, where he worked with our very own Dr. Mehta, and then came here to Atlanta and continued some of his work as part of our research track with Dr. Mehta and others, and is going to be going back to Los Angeles to do interventional cardiology next summer. And he's going to talk to us today about mechanical support. Ahmed.
Thank you, Dr. Williams. Today my talk is pipes and pumps, the evolution of mechanical reperfusion and support. And in my talk, I will highlight some of the history of how things evolved in the field of coronary angioplasty and mechanical support. To me, this is a very interesting topic, and instead of showing you slides on what is the latest guidelines and how to manage these conditions, which you can read at any time at your convenience, I will tell you some stories that you can listen while you're driving to work this morning. I have nothing to disclose. I'm going to start with a case that our team took care of in the CCU last month. This is a 62-year-old male patient, has past medical history. As you can see, coronary artery disease, PCI to the RCA a few years before presentation, the trigger tachycardia status post ICD, cardiomyopathy with ejection fraction of 10%, and atrial fibrillation. He presented with a 4 days history of shortness of breath. His medication listed here. His right heart cath during his hospitalization, while he was on Miller of 0.6, right atrial pressure of 14, RV pressure of 47/20, PA pressure 50/35, and wedge pressure is pretty high of 34. His cardiac output was 3.3, and cardiac index at that time 1.3. He was admitted initially for acute exacerbation of heart failure. He was admitted to the heart failure team. He was diuresed. Miller initially started as 0.375. 2 days after, he developed acute renal failure. He was very short of breath, not doing well pretty much. Furthermore, he failed cardioversion for his atrial fibrillation. Miller increased, and then a few days after, he was transferred to the CCU. Impella CP was implanted, it was inserted urgently. He failed to have AV nodal. Well, he had the AV nodal ablation. However, he did not do well after that. Miller was increased and dobutamine added as well. The second morning, there was a significant hemolysis, probably due to the Impella. So he was taken to the OR for emergent Impella 5.5, CRT initiated, and flow line initiated as well. He was maintained on pressors and Impella support, and of course, he was still on CRT. He maintained like that for 10 days, and then after that, he went for Centromac support for RV and LV support. The next morning, he was extubated, and after that, he initiated physical therapy. This case just reflects the course of myocardial infarction complicated with advanced cardiomyopathy and requiring mechanical support despite relatively successful reperfusion of the coronary artery. And for that, I would like to talk about how did we get here from reperfusion taking care of myocardial infarction to supporting the left ventricle or the heart with the mechanical support. So my talk is going to be two parts. First part is the evolution of mechanical reperfusion. I was listening to a lecture by Dr. William O'Neill 2 years ago, and he mentioned the story of President Eisenhower heart attack. Actually, I bought the book by Leslie, and it was really an interesting book. And I will give you kind of like a summary of his multiple heart attacks. This is the President Eisenhower during his vacation in Hawaii in 1946 after World War II, when he had an episode of chest pain. It was thought to be his first heart attack, actually. However, who knows at that time what was it? He was known to be a heavy smoker, as you can see in the picture. He's smoking. It was hypothesized that there is maybe a link between smoking and cholesterol built up in the coronary trees on autopsies at that time. Then in 1955, President Eisenhower was playing golf in Denver, also vacationing, visiting his mother-in-law. He was staying on the second floor of the house. On the ninth hole, he started to have chest pain, and actually it was more described as just discomfort. He went home, and the presidential physician at that time, Paul Dudley White, was called and saw him around midnight. He was nauseous, diaphoretic, with abdominal pain. In his physician record, it says that he lost his blood pressure for 15 minutes. So basically, he was in a cardiogenic shock at that time. He woke up in the morning and still having chest pain. They called the Fitzsimons Army Hospital at that time to transport a big EKG machine that took 4 corpsmen to carry it upstairs to his room. EKG was done, and sure enough, it showed a myocardial infarction. The treatment at that time for myocardial infarction was just bed rest, nitroglycerin, and morphine. So that was how he was treated at that time. And after the press gathered outside his mother-in-law house, he didn't want to panic the country, so he walked downstairs while having an acute MI, walked to the ambulance, and was hospitalized at the Fitzsimmons Air Force Base Hospital from September 25th to December 12th. So that was 3 months. So basically, here on the country, from a hospital for a good 3 months until he recovered. His physician strongly at that time advised him to retire because of the stress being a president. But he, against medical advice, he decided to continue. Actually, 2 interesting facts. When the word got out that the Eisenhower had a heart attack, the stock market dropped in the largest amount since Depression. And it was the largest drop in 1 day. Imagine this, if he would have died, it's kind of like the second fact, if he would have died at that time for this cardiogenic shock, Richard Nixon would have been the president of the United States as of September 1955, and he would have been easily elected in 1956. So all the events that happened during that period of time that kind of like defined America, like Cuban Missile Crisis, Vietnam War, eventually the JFK assassination, all these things would have been changed. But who knows? The president survived at that time, and he kept running the country. This is him at Walter Reed Hospital 12 years after, with President Richard Nixon visiting him. He was admitted with a diagnosis of status angiosis. That was used to be called in that time. And it's basically just severe remitting, uncontrollable chest pain. He had at least 12 episodes of VF arrest, which he was resuscitated. And at that time, Chris Bernard, we'll talk a little bit about that, started to perform heart transplant in South Africa. So the word got out that he might need a heart transplant. Very interesting, 9 Americans at that time volunteered to be donors for the president, to give their hearts to the president. This is pretty fascinating, I think. In March 1969, President Eisenhower died, and autopsy showed 3 occlusion of his LAD with the tight stenosis of his circs. So probably that's what's causing all his VF arrest. Think about this for a moment. If the President Eisenhower presented to the ED nowadays, he would have had an EKG in the ED, went to the lab, radial access, revascularized, and would have discharged from the hospital in a few days. This is just to show you how things can evolve over time. The mortality rate from cardiogenic shock back in the 1950s were around 90%, which decreases to 10% once streptokinase was used, and then and to treat acute myocardial infarction. And this rate even went down in the late 90s to 2000 after starting angioplasty. This has all started many years ago, and actually mainly in the 80s, when acute myocardial infarction thought to be due just to coronary thrombosis. 2 centers in the early 80s, one in Germany and one in Washington, started to do emergent bypass. And in order to do bypass, of course, you need an angiogram. So they saw that patients who presented within the first 4 hours had marked total occlusion of their culprit artery. And after that, they start to recanalize the occluded artery. So the thought was, if there is, it seems to be there is a spontaneous thrombolysis, and if we can accelerate that, we would help opening the vessel. This is how the field of streptokinase started, actually. Now, this is an old angiogram which was performed by Dr. William O'Neill in the early 1980s, showed an occluded RCA, as you can see here. And after giving intracoronary streptokinase, the vessel opened up a little bit. It opened up. There is a little bit of kind of reperfusion, however, still pretty tight. Then after that, this led to a study in 1983. This was an early study comparing intracoronary streptokinase versus placebo in acute myocardial infarction. And although streptokinase was more effective than placebo in achieving reperfusion, there was no improvement in left ventricular function as a result of reestablishing coronary flow. So the question was, why is that? If you can see here, the streptokinase actually, as I said, it's opened up the vessel, but it did not open it totally. At the same time, in Switzerland, Dr. Gronzig was performing balloon angioplasty electively to open up stenotic vessels. This is one of his prototype, if you see. The catheters at that time were very complex and required skills to maneuver them. The syringe actually at this end was made of glass, often breaks, glass shattered and injured the operator. And therefore, they used to place it in a metal cage, as you can see here. Dr. Gronzig was a coronary physiologist, and he used the pressure gradient across the stenotic lesion to assess successful angioplasty. And this concept translated now to what we use now, FFR. So this is literally almost 30 years after when we started using his techniques also. Followed that, Dr. Hartzler in Kansas City, he thought that how about we do just angioplasty in patients with acute myocardial infarction. And in 1983, he published his paper about performing this. He found that with angioplasty, there was an increase in left ventricular ejection fraction with significant improvement in function. This finding was not seen, as I said, with streptokinase. This paved the road to a prospective randomized clinical trials of intracoronary streptokinase versus angioplasty in 1985 by Dr. O'Neill. He found that angioplasty and TPA produce similar rates of early coronary reperfusion. Angioplasty is more effective in elevating coronary stenosis, and angioplasty may result in effective preservation of LV function. However, the study was a small study, and then also there were very few centers who were actually capable of doing angioplasty at that time. So after that, a group of investigators decided to perform a bigger study, and maybe most of you are familiar with is the TAMI trial. Rick Topol published the result in 1987, and here's the flow chart for the study, as you can see. So a patient presented with acute myocardial infarction within 4 hours of symptoms. They get a TPA, and then a coronary angiography. They transport to a hospital which is capable of doing coronary angioplasty within 90 minutes. And they see if it's occluded, then they do angioplasty. If it's patent, then they just don't randomize them. They exclude them from the study. If it's patent and more than 50% stenosis, they randomize to immediate angioplasty versus deferred angioplasty. Shockingly, mortality rate was higher in patients receiving angioplasty compared to those who received thrombolytic therapy alone. And that was replicated the same in the European study and then at the TIMI-2A study as well. So it was a surprise at that time. Everyone thought angioplasty is bad and should be avoided. In fact, Washington State prohibited insurance to reimburse angioplasty procedures at that time. So hearing this, I'm sure electrophysiologists were very happy, including Stephanie. She heard this, she took a boat, barbecuing, celebrating. This is a live image of Nick Chocolati. He didn't like this, and he said this cannot be true. So he's going for interventional cardiology. And I agree with Nick. If we look at the different studies, the TPA at best, here if you can see, can achieve around 50% TIMI-3 flow, while angioplasty, it's kind of like achieve more than 95% of TIMI-3 flow. So to prove that angioplasty works in acute myocardial infarction, interventional cardiologists started working to solve this mystery. And if you're wondering, this is Sule. This is Dr. Jabber. He's the champion of pull-ups competition at Emory Midtown. And this is Dr. Kumar. I don't think he was doing anything really. For that, SAMI trial came out and published in 1992. And sure enough, it showed that adding IV streptokinase therapy to angioplasty failed to enhance LV function, increase bleeding, CABG rate, hospitalization, and cost. Angioplasty therapy for acute myocardial infarction should not be routinely performed with adjunctive to streptokinase therapy. The conclusion was it's not actually the angioplasty is bad, but the combination of angioplasty with streptokinase. This is an autopsy of a patient who received the angioplasty by, TPA followed by angioplasty, which was significant. You can see there's a lot of wall hematoma, hemorrhages, and when performing angioplasty after TPA, the lumen occluded with a ruptured hematoma. So in 1993, the first randomized clinical trial comparing angioplasty to streptokinase was published and showing better outcome in angioplasty arm compared to streptokinase arm. And this was replicated in many studies. And in fact, there were 26 trials between 1995 and 2005, and all showed the same result, that angioplasty is superior to streptokinase. Nick is now happy. He took the boat from Stephanie, and he's celebrating. So what is next? After opening a vessel, we want to decrease the infarct size and potentially decrease the rate of the associated complication. There is a data suggesting that intracoronary cooling will decrease the infarct size significantly. In the earlier stage of investigation, the cooling catheters initially required 45 minutes to reach the target temperature. So it fell out of favor because really nobody had that much time in the cath lab to do this. Newer catheters reported that it's actually required only 9 minutes to achieve the target temperature. This is something I believe that we will see soon in the management of acute myocardial infarction. Similarly, the use of supersaturated oxygen therapy for 60 minutes in the left main shown to decrease the infarct size by 26%. This is actually was approved by the FDA. I'm not sure when are we going to start using this. Another approach to limit acute myocardial infarction complication is to unload the left ventricle. And this is a study, it's a kind of pilot study where they used FLCP upon presentation for acute myocardial infarction, followed by immediate reperfusion in one group versus 30 minutes delay in reperfusion. It seems that in the large myocardial infarction, and it's defined here as the elevation of more than 6 millimeter on EKG, the delayed approach was preferred actually. And in general, when we try to reperfuse the infarcted area immediately, is actually our goal is to decrease the infarct size to prevent complication, like our patient who developed cardiomyopathy, which eventually required mechanical support, which will lead me to the second part of my talk, the evolution of the mechanical support. Again, it started really many years ago. In 1927, Charles Lindbergh was the first pilot who flew across the Atlantic Ocean. He was also an engineer. He was very involved in the development of artificial heart, which is kind of like very interesting. He said if we can build a machine that can fly the Atlantic Ocean, we can build one that can fix a broken heart. Eventually, he worked with another engineer, Alexis Carrel, to build the first artificial heart. Their first model was made of a glass and featured in the cover of the Time magazine at that time. And this model is actually still exists in the Rockefeller Museum in New York City. At the same time, there were scientists who were working on the idea of transplant to fix a damaged heart or organ in general. The pioneer in this was Dr. Vladimir Dimokhov. He's a Russian PhD, not an MD, who was involved in cardiac physiology and animal transplant. He was very famous in one of his surgeries that was not popular. As you can see in this picture, the dog with two heads. He was pioneer for heart transplant by actually showing that we can perform organ transplantation. So what I'm trying to say here is there were two parallel ideas, one mechanical support and one transplant. Both the goal was to fix a diseased heart. Eventually in 1953, Dr. John Gibbon, who was actually the first inventor of the heart-lung machine, followed by Dr. DeBakey in 1954, who invented the roller pump, which became essentially part in every heart-lung machine in the world nowadays. Dr. DeBakey was a surgeon and an inventor, and at that time seems to have a big influence in the Congress. In 1963, Dr. DeBakey testified in the Congress to support the American Artificial Heart Project by saying, experimentally, it is possible to replace the heart with an artificial heart, and animals have been known to survive as long as 36 hours. This idea, I'm sure, could reach full fruition if we had more funds to support more work, particularly in the bioengineering area. 1 year after, the NHLBI established the United States Artificial Heart Program, and this is President Lyndon B. Johnson congratulating DeBakey for having successful NIH fund to support the program. The goal at that time was to build the first artificial heart by 1970. And I'm not sure if you know, during that time, there was a Cold War between Russia and the United States. Russia launched the missile to the space, and the United States wanted to put the first man on the moon. Similarly, they wanted to develop the first artificial heart. Dr. DeBakey was on a fast start. He performed a 4-hour surgery in 1966 on this young lady from Mexico and replaced both mitral and aortic valve. However, it was not possible to get the woman off the heart-lung machine. Therefore, one of the mechanical support prototypes that he invented implanted. Her heart was supported for 10 days, and at that time, and her heart came back. The assisted device was explanted, and the patient did well eventually. At the same time, there was a big race, an actual race between giants to perform the first human heart transplant. Norman Shumway at Stanford, Richard Lauer in Virginia, and Adrian Kantwitz in New York City, and Christian Bernard in South Africa. In 1967, Christian Bernard performed the first human heart transplant on a young patient with ischemic cardiomyopathy. And at that time, it was really difficult to know, how this patient accepted the heart transplantation. And Dr. Bernard said, for a dying man, it's not a difficult decision because he knows he's at the end. If a lion chases you to the bank of a river filled with crocodiles, you will leap into the water convinced you have a chance to swim to the other side. Interesting fact: the donor was a lady who was involved in a motor vehicle accident with no brain function, and at that time they didn't know what is the kind of the policy or what's the process of explanting the heart. So they took her to the OR, extubated her. They wait until her heart stopped, then transferred her heart to this man. This man survived 18 days and died because of a pneumonia. They were afraid of rejection, so they intensified his immunosuppression regimen, developed pneumonia after that. At that time, again, there were two major scientific achievements of the century. One is flying to the moon in July 1969, and the second is, of course, the first human heart transplant. Following this, every patient who got transplant died. Surgeons gave up until the 80s when cyclosporins came out and patients started to actually live longer. And due to the disastrous result of the heart transplant, scientists were looking on total artificial heart. This is Dr. Leota, who initially was working with Dr. DeBakey lab in Houston, Texas. He implanted artificial hearts in animals, but unfortunately none of the animals survived. In fact, they're all dead by the next morning. Dr. Leota left Dr. DeBakey lab and joined Dr. Cooley's lab across the street in Houston in 1964. At that time, there was a big feud between Dr. DeBakey and Dr. Cooley, and this is actually reached to the media, and you can see here, this is the cover magazine for Life magazine at that time. In 1969, Dr. Cooley implanted for the first time Dr. Leota's total artificial heart in a 47-year-old male presented with ischemic cardiomyopathy. The total artificial heart functioned for a good 64 hours until Dr. Cooley found a donor for transplant, and the patient eventually died 32 hours after a cardiac transplantation due to pseudomonas pneumonia. After that, there was a continuous improvement in the total artificial heart. Dr. Kolf, as you see here, who was the inventor of the first artificial heart and dialysis machine during the World War II, he used to implant these devices in animals. As you can see, this is one of his animals. This is Frederick, one of those sheep who had an artificial heart. You can see there are tubes coming out of the back of Frederick. And Frederick had a Jarvik 7 total artificial heart, which lasted for a good 6 months. And this is Lillian with the artificial heart and a portable driver. This lasted 2 hours. They placed it on Lillian's back, and then Lillian was able to kind of move around with it. After that, in 1981, actually a year before that, Dr. Akutsu from Japan joined Dr. Cooley's lab. In 1981, Dr. Cooley wanted to implant Akutsu total artificial heart in a patient. So he invited the media and Time magazine to join the operation, photographed the entire event. And unfortunately, the operation did not go well. This was one of the images that was in the magazine. The heart was too big for the chest. The patient stayed like that until Dr. Cooley found a heart for transplantation, which he did, but the patient also died shortly after just because of complications. A year after, Dr. Joyce at University of Utah performed actually the first successful permanent total artificial heart on a volunteer who was a dentist, Dr. Clark, who had non-ischemic cardiomyopathy at that time. You can see the procedure went well, and the patient did really well for 112 days, and he died of a bowel bacterial overgrowth due to the excessive prophylactic antibiotics that he was receiving. I want to draw your attention to this. He was connected to this 400 pounds driver. So this man didn't have really any life. He was in the hospital. Some people, they're pushing this 400 pounds driver with him. But he knows that. He's not going to play golf. But again, this was kind of like paved the road to improve these devices. And actually, these devices worked. In 1984, after that, the FDA approved the artificial heart or mechanical support for a bridge to transplantation prior to the use as destination therapy. Following that, there was a big interest in developing LVADs only for bridge therapy to transplant. Dr. Poirier and Dr. Fraser working on this pump here, which was bought by Thoratech and then eventually was approved for clinical trials called the Remesh Trial, which most of you know. It is a randomized clinical trial comparing optimal medical therapy versus pulsatile flow LVADs in a non-transplant candidates. And very impressively, it showed that in 1 year, 52% of those who received LVAD survived versus only 25% who received medical therapy. Now, this for the first time, the use of mechanical support shown to be much better than the medical treatment, and that was the FDA approval. The FDA approval for the LVAD as a destination therapy, rather. Then the idea of placing smaller pumps in the ventricle came out. Richard Wampler, who came up with the idea of having an impeller inside this elastic tube. It had a flexible cannula, as you can see here. Inside there is a high-speed turbine, that can run up to 28,000 rounds per minute, and this pump could pump almost a gallon of blood from this end in the ventricle to this end in the aorta. And this idea came from an idea of Archimedes' screw concept. As most of you know, in farms, water is pulled from a tunnel and pushed to another tunnel, as you can see here, via the Archimedes screw concept. This concept actually paved the idea of developing the continuous mechanical support. And this is pretty similar to what we use now. It's pretty much the Impella that we have. They call it at that time, hemopump. In the 70s and 80s, Baylor College of Medicine had an affiliation with NASA to study astronaut physiology, but it had nothing to do with mechanical assisted devices. David Saussure was a NASA engineer who ended up receiving a heart transplant in 1984. Dr. DeBakey and Dr. George Noon here had discussion with the engineer about whether his knowledge of rocket pumps could help build a mechanical pump for humans. He introduced them to three more other engineers who had experience with axial flow pumps, which are used to pump fuel in a shuttle. They start working on it soon after he recovered from his surgery, and gradually that work became a formal association with some funding, and that was actually the birth of the axial flow pumps. Recently, the concept of fully magnetically levitated circulatory pump was introduced, and it's similar to the train in Japan. The train in Japan actually does not touch the rails. It's magnetically levitated. Therefore, it can easily go like 300 kilometers per hour. It's pretty fast because of the decrease of the friction as well. Some of the mechanical support, now they start developing these mechanical support based on this concept, and it's a less energy consumption and also less friction. So that was pretty much a game changer. I'm going to finish up with this table to show the different available devices. As you may know, I'm familiar with the HeartMate 2. The implant location is in the chest and abdomen. The flow is axial centrifugation. Impeller suspension is mechanical bearing. The weight is about 280 grams. Maximum output is about 10 liters per minute. And no pulsatility for the device. The edge VAD is pericardial, sitting in the pericardium, centrifugal, hybrid magnetic, hydrodynamic. It's a lighter, 160 gram, and maximum output is 10 liters per minute. Jarvik 2000 is actually intracardiac. It's axial, ceramic bearing. It is very light, 90 grams, and it can pump 7 liters per minute outcome, and it has a pulsatility. Now we start seeing more and more HeartMate 3, pretty much here at EUH. It's a pericardial. This is one of the magnetically levitated. It weighs 220 grams and pumps 10 liters per minute, and it's pulsatile. And then hopefully we'll see also soon the MVAD. Again, it's similar to the HeartMate 3, pretty much. Pumps a little bit less, however, it's very, very light. So hopefully we'll see this. Finally, I would like to thank all of you for listening. I would like to thank Dr. Clemens for being a great teacher, Dr. Williams for being an amazing support for his fellows. I had a great time working with Dr. Gupta, Sahu, and Dr. Laskar in the CCU, and of course, the wonderful team of resident and APPs in the CCU. Shout out to the heart failure team who are taking care of these sick heart failure patients here at EUH in Midtown. And finally, I would like to thank my co-fellows who I always enjoy working with them. Thank you so much. Any questions?
Thank you, Ahmed. Very good. Yeah, I was going to agree. Any questions from the group? Well, Ahmed, now that you've studied the history of mechanical support, I mean, do you think we are close to a day when LVAD as destination therapy becomes the sort of go-to therapy for patients with advanced heart failure?
I think it's a very interesting question, Dr. Williams, because if you see the evolution, I think this has all happened in terms of the mechanical support in the past, maybe like 15 years, and especially now with the new devices that probably in the past 10 years. It might take time, I agree, but I think that's going to happen. It's going to be the heart is going to be fully supported in a mechanically supporting devices, and I think most of the complication we're going to take care of eventually.
Hey, this is Raja Laskar. I mean, that was a fantastic talk and really great historical overview of mechanical support. Just a comment, it really is, certainly the last 10 to 15 years have seen a really market evolution in LVAD technology and therapy to where, you mentioned the Rematch trial, where the people who went through that, after they got through that study and trial, you're like, was it really worth it? And now we have, patients who are living not just longer, but with fewer complications. To Dr. Williams' question, yeah, I think that these devices are getting smaller. Both large device companies are working on a drive line-less device, and that will be a huge game changer as far as acceptability for clinicians and physicians and families for this device. And then that really opens up the question of patients who are not necessarily just stage D, but who are more stage C, who get a device and can increase their cardiac output by 2 or 3 liters with fewer complications. I think that is on the horizon in the next 5 to 10 years from a driveline-less device. Just as a, I don't want to say a plug for our program, but today Dr. Dinashman is doing a biventricular HeartMate 6 implant on a patient in the 5E ICU, a very young patient who's very ill. We follow about 113 long-term LVAD patients. The majority of those are destination therapy patients, and our numbers across Emory Healthcare, including Emory St. Joseph, have doubled in the last 24, 48 months. So yeah, it's definitely not cutting edge anymore. It's kind of standard of care for stage D patients. And again, once we we do get a drive line-less device, which is on the horizon, it'll be even more of a game changer, if you will. That was a terrific talk. Thanks, Ahmed.
Thank you so much, Dr. Laskar. Thank you.
The other just historical note I'll make, you mentioned how Dr. Paul Dudley White was the presidential physician for for President Eisenhower. And then 2 presidents later, as many of you know, who trained or been at this institution, Dr. Paul Dudley White's protege, Dr. Willis Hurst, became the presidential physician for for President Lyndon B. Johnson. So a little continuity there.
Amazing.
Yeah, this is Andy Smith. Great talk. So in the late 80s, early 90s, we had available, I think you showed the Thoratec device that was external, where you could actually see the blood going through the pump, and it was hooked up to that huge console. And those pumps from a standpoint of delivering blood flow to the body were excellent. The problem was the patients could not be discharged from the hospital with it. But I recall we had a patient that had both right and left-sided Thoratec devices who went into ventricular fibrillation and couldn't get the patient out of it. Eventually, we moved the patient out to the floor and took him off telemetry. And it was on telemetry, was on the floor for about 6 months before transplant. At the time of transplant, somebody did an EKG per protocol, and the patient had gone back into sinus rhythm, which we didn't even know that. So the spontaneous conversion of ventricular fibrillation over a number of months with mechanical support. But the issues with those pumps were the patients couldn't leave the hospital. So eventually the pumps became internal. The battery supply was developed. And then with the HeartMate XVE, it was a great pump, but the pump fails generally within about 18 months. So the mechanical issues of with all the different moving parts, the pump would break down. That pump actually had a surface that the endothelium would grow over, and the patients only required aspirin. They did not require anticoagulation. So the other issues that we currently deal with are the issues of the interface between the pump and the bloodstream with thrombosis, the need for anticoagulation, the fact that the non-pulsatile or the continuous flow pumps, even though they, like with the HeartMate 3, does have some minor pulsatility, but in general these are non-pulsatile pumps, and that results in issues with GI AV malformations and that type of thing. So that's an issue. And then the key issue that we face now is just trying to get these devices totally internal, so that there's not a drive line with the issue of infection. It's been each few years that the technology improves.
Sure. Thank you so much, Dr. Smith.
This is Neil Dickert. So the sort of other end of the spectrum or other end of the disease process you talked about, which I thought you did a nice job presenting. The evolution is the approach towards acute MI with cardiogenic shock, which is really interesting to hear the story of angioplasty is good, then it's bad, then it's good, instead to me, the real lesson in all this is the importance of this really, and it takes a while, but a really important combination of reasoning through what's happening and doing really good clinical trials to demonstrate what does and doesn't happen, or what does and doesn't work. We're in a spot right now where I think, if you take the acute cardiogenic shock space, it's a perfect example of, the truth is we don't know what to do with regard to the role of mechanical support. Hopefully there's some large trials in Europe, and there will likely be a large trial in the US looking at this soon. But it's amazing how we have tools, particularly in pellet pump, that have arguably no data, no good randomized data to support whether it really improves outcomes, yet all of us think there's important potential roles for this, and we have to figure it out. So I thought you did a really nice job kind of going through the history of how trials have helped us to know what we do and don't know.
Thank you, Dr. Dickert. Thank you.
I'd like to add a couple of comments. Ahmed, that was really a very nice talk. I give you a little bit of additional historical perspective. So I worked as a student at VCU with Richard Lauer from 1967 to 1970, and was involved with the initial transplants that were done there. And then in 1969, I went to a meeting at the National Academy of Sciences, which was a state-of-the-art session about heart transplantation versus total artificial heart. And getting back to the pumps, I think one of the most interesting things is that here we are basically 50 years later, and the real challenges to the success of these pumps has been the blood pump interface and the thromboembolic issues that relate to it. And I think that we're getting close to solving these problems with lower residual volumes and less trauma to the blood and all the other issues. But it's interesting to see that over 50 years, the fundamental issues that we have to address to make this success persist to this day.
Definitely. Thank you, Dr. Thames.
Ahmed, this is Mahmoud Abdu. Fascinating
Yes.
talk, very, very good and thorough, and a great historical background. I want to echo Neil on his comment, and you kind of very nicely pointed out very good points about acute MI and cardiogenic shock. And interestingly, you mentioned Dr. Bill O'Neill, who's been a champion of this actually for the last few years. We've been always taught door to needle time, door to balloon time is muscle. But perhaps this approach is changing now, especially with acute MI and cardiogenic shock. Right. Now the teaching is all about unloading the heart, the ventricle first, and then opening the coronary and reperfuse. I can argue that if you don't have adequate coronary perfusion, the coronary pressure gradient is low, especially in cases of shock, because your EDP is very high. What use will opening an artery and putting a stent in with no flow? So this concept actually, Dr. O'Neill, kind of the champion of the Detroit Cardiogenic Shock Initiative, has shown that impella support or mechanical circulatory support, or in other words, unloading the left ventricle before reperfusion actually improves survival. Right. In a very, very remarkable, remarkable data that he showed. And like Neil said, this is not randomized, this is not blinded. However, we're seeing some signals here that may potentiate extra research in this area. Fascinating talk, and good luck to you.
I appreciate it. Thank you, Dr. Ahmed. Thank you so much.
This is Andy again. Just a comment when I was hearing the story of the early donor who was taken off of respirator support, and the heart was taken after it stopped beating. For those who aren't aware, we've been part of the donation after circulatory death trial, in which patients who are not brain dead but are being taken off life support to be allowed to die, that after the heart has stopped for 5 minutes, it can be procured and can be resuscitated with a device made by Transmedics. And you can actually see the heart beating, it's perfused, and you can check lactate levels and enzymes and that type of thing to be sure that the heart is functioning properly. I think since January, we've done either 7 or 8 of these types of transplant after circulatory death that we would not have otherwise done. And the trial, the initial results across the country look favorable, and we're going into a second phase of the trial in December.
Thank you, Dr. Smith. Thank you so much.
The other comment about that, though, is that when patients are taken off a respirator support, if they don't die within, I think it's 25 minutes or so, or if their blood pressure stays below a certain level, that those hearts cannot be used. So there's criteria of how, when they're able to procure and when it may be safe, at least within those trial parameters.
the
Wow, very
the ethicist in me has to at least raise the interesting point, I think, which is that the donation after cardiac death has been, as Andy mentions, really is opening up new avenues. The interesting challenge is what Andy mentioned at the last piece, which is that there's a very real sense in which we are creating a solution to a problem that we created with the definition of brain death being equated to death, which is a definition that was largely, and I think it's important for people to just be somewhat aware of, was in truth created in order to make a pathway through which organ donation could be accepted. And this is a good example of one where we have potential donors that we are, because of the way that the definition of death has been constructed, we're forced to let them go through this process that jeopardizes donation. It is a really interesting challenge. I'm not proposing a solution to that, but it's interesting. The situation Andy mentioned at the end, where it's tragic when people are otherwise good donors, that we have to let them go through a circulatory arrest in order to make them eligible for donation. I don't know the fix to that problem, but it's a tough challenge. It feels self-created, and it's hard to know the right path forward. But it's wonderful that we're getting at least making progress with regard to the DCD protocol.
The preceding program is copyrighted by Emory University.